Good evening, everyone present here. Dr. Sanjana ma'am, you can start sharing your PPT. We can be starting then.
Good evening, everyone. So today is part 3 of our dermatology class for MRCP part 1 and 2. So today we'll again be discussing few important topics based on focusing on your exam point of view. Yeah, so today's first topic is pyoderma gangrenosum. So you can make a note of the lesion, how it looks. It can be very mild, like how it looks in the first lesion, and it can also form ulcerating lesions, like how it's seen in the others. So it typically is an expanding ulcer with a polycyclic or serpentinous outline and a characteristic undermined bluish edge. The pathogenesis is unknown and it is presumed to be an immunological disease. What are the features of pyoderma gangrenosum? So it typically affects the lower limbs, most common on the lower limb and in scars of or previous sites of trauma. It is initially seen as a small red papule. Later, it becomes deep red and forms a necrotic ulcer with a violaceous border or a purple colored border. Okay. And it can later be accompanied by systemic symptoms, for example, fever and myalgia. Okay, so what are the causes of pyoderma gangrenosum? Most commonly, it is idiopathic in almost 50% of the cases. And another important cause is inflammatory bowel disease. It can be either ulcerative colitis or it can be Crohn's disease. Estimates of prevalence in IBD ranges from around 2 to 5%. It tends to be associated with colonic involvement and is perhaps slightly more common in ulcerative colitis compared to Crohn's disease. Other causes include rheumatoid arthritis, SLE, malignant disorders like myeloproliferative disorders, lymphoma, leukemia, monoclonal gammopathy, and primary biliary cirrhosis. Coming on to the management of pyoderma gangrenosum, the potential for rapid progression is very, very high in most patients, and oral steroids are used as the first line of treatment. Other immunosuppressive therapy, for example, cyclosporin and infliximab, have been shown to be effective in resistant cases. All right, so remember the first line will be steroids and second line will be immunosuppressants. Next is another very important topic, scabies. This is very important when it comes to the causative organism, how it can spread, the population that it affects, and what part of the body it affects, and how it appears, and also the treatment. Okay, so scabies is caused by the mite Sarcoptes scabiei and it is spread by prolonged skin contact. Typically affects children and young adults. Scabies mite burrows into the skin, laying its eggs in the layer of stratum corneum of the skin. Okay, so remember that the eggs are found in the stratum corneum layer. The disease is associated with intense pruritus and itching. It is caused by type 4 hypersensitivity reaction to the mites and the eggs laid by the mite. Which occurs approximately 30 days after the initial infection. What are the features of scabies? First being intense pruritus and itching. Okay, it presents with a dermatitic looking rash on the body, mainly in certain places. For example, soles, genitalia, buttocks. It is also associated with the presence of linear burrows on the sides of the fingers, where interdigital webs are seen on the flexor aspect of the wrist. Okay, burrows are pathognomic of scabies. So how do you diagnose that it is scabies? Whenever you see linear burrows, it has to come to your mind that this might be a case of scabies. It has a predilection for web spaces and around the nipples as well. And in infants, the face and scalp can also be affected. Some secondary features can also be seen in scabies because of the intense itching, like excoriation and secondary infection. Coming on to the treatment of scabies, permethrin 5% is the first line. The second line would be 0.5% malathion. Okay, pruritus persists for up to 4 to 6 weeks, even post eradication. That is, even post 4 to 6 weeks of the treatment, the patients can have intense itching, mainly because of the hypersensitivity. The cream should be applied everywhere below the neck, not merely where the rash is. Okay, so it has to be the permethrin or the malathion cream has to be applied evenly everywhere, and close contact should be avoided with other people until the treatment is completed. All household and close physical contacts should also be treated at the same time. Okay, even if the other members of the family are asymptomatic, they will have to undergo treatment as a prophylaxis. Laundering, iron, or tumble drying of the clothing, bedding, towels, etc., has to be done on the first day of the treatment itself to kill the mites. Otherwise, even after treatment, it can recur. Patients should be given proper instructions as to how to use the creams and how to prevent spreading of the infection. So the cream has to be applied to cool, dry skin, mainly between the fingers and the toes, under the nails, the armpit areas, and creases of the skin where there's excess of sweat accumulation. All right. Also, it has to be allowed to dry and it has to be left on the skin for at least 8 to 12 hours for permethrin and for at least 24 hours for malathion. Okay, after which it has to be washed off. And reapplication of the insecticide if it has been removed during the treatment period. That is, if they have washed their hands or something, it has to be removed. Okay, the treatment is again repeated after 7 days. Coming on to a variant, crusted Norwegian scabies. Crusted scabies is seen in patients with severe immunosuppression, especially HIV patients. Okay, so the crusted skin will be teeming with hundreds and thousands of organisms, mainly because of the immunosuppressed status of the patient. So here the treatment of choice will be ivermectin. In a regular case of scabies, you give permethrin or malathion, whereas in crusted scabies, it is ivermectin. This is a very important exam question.